afternoon, everyone. So today I will present on the case fatality risk among individuals vaccinated with the rVSV vaccine. As my colleague Sophie just discussed, the rVSV vaccine was highly effective at lowering the risk of Ebola virus disease during the 10th EVD epidemic in the Democratic Republic of the Congo. Though 84% effectiveness at preventing EVD means that some vaccinated people will still get sick. This underscores the importance of describing the vaccine's effectiveness against severe disease and death, which is what I will discuss in this presentation. For the first and second objectives of our analysis, we consider the time between vaccination or lack thereof and symptom onset according to vaccination status. And I will discuss how we define vaccination status later in the presentation. The first objective is to assess the case fatality risk, that is the number of EVD-positive deaths divided by the total number of EVD-positive patients according to vaccination status. The second objective is to assess cycle threshold values at admission according to vaccination status. And cycle threshold is an indication of disease severity. And for the third objective, we consider the time between vaccination and administration of EVD-specific treatment to explore any positive or negative interaction between the vaccine and treatment. So our analysis is a retrospective cohort analysis using the same data source as my colleague Sophie, that is the compiled line list from Ebola health facilities. However, unlike Sophie's analysis, we included only EVD-positive patients. We also looked at the entire duration of the 10th Ebola epidemic in the DRC. So now let's review how we define vaccination status. Recall that the incubation period of EVD is 2 to 21 days. Accordingly, we know that people who were vaccinated 21 days or more before their symptom onset were vaccinated before their EVD exposure. This is our first vaccination status category. And likewise, we know that people who were vaccinated 2 days or fewer before their symptom onset were vaccinated after their EVD exposure. However, defining the next vaccination status categories is a bit trickier. However, we know that antibody protection occurs 10 days after vaccination, and that other research has used the same cutoff when considering vaccination status categories. As such, we considered those vaccinated 10 days or more before symptom onset to have probably been vaccinated before EVD exposure. And those vaccinated 3 to 9 days before symptom onset were classified as probably vaccinated after EVD exposure. So let's next consider our statistical analysis. We calculated the case fatality risk and its 95% binomial confidence interval among patients with confirmed EVD by vaccination status, comparing case fatality risk using two-sided Fisher's exact testing, cycle threshold values for nucleoprotein at admission according to vaccination status were compared using Wilcoxon rank sum testing, stratified exploratory analyses were performed to calculate the case fatality risk according to the EVD-specific treatment received and the time from symptom onset to admission at an Ebola health facility. To explore the effect of vaccination on EVD-related mortality, we used Poisson regression models with robust error variance. Now let's look at the outcome of our first objective, case fatality risk according to vaccination status. So in this table, we present the case fatality risk and crude risk difference by vaccination status. Let's start by focusing on the first two rows of data in the table. Among the patients who were vaccinated, the case fatality risk, among those who were not vaccinated, rather important, the case fatality risk was 56.2%. This is in sharp contrast to the patients who were vaccinated, considering any time from vaccination to symptom onset. The vaccinated patients had a case fatality risk of 25.1% compared to those who were not vaccinated, meaning that those who were vaccinated had half the risk of death. Now let's consider the timing of vaccination, looking at the additional rows of data in the table. We see that compared to unvaccinated patients, the earlier a patient was vaccinated prior to their symptom onset, the lower their case fatality risk, dropping to as low as 17.5%. Importantly, vaccination even only 2 days or fewer prior to symptom onset after EVD exposure, when a patient was already infected and incubating the virus, resulted in a case fatality risk of 27.3%. This is still less than half that of the unvaccinated patients in our cohort, and to our knowledge, lower than case fatality risks reported in all previous literature and outbreaks. This means that vaccination, even when administered late, is still beneficial for reducing the risk of death. Now let's look at the adjusted analyses. In this analysis, all estimates were adjusted for risk factors for death from EVD that had been identified in previous studies or by an expert in the field, including age group, sex, healthcare worker status, time from symptom onset to admission, and EVD-specific treatment. We see here that those vaccinated 2 days or fewer before symptom onset had an adjusted risk ratio of 0.56. The lower the relative risk, the higher the protective effect. Those vaccinated 3 to 9 days before symptom onset had an adjusted risk ratio of 0.44. And those vaccinated 10 days or more before symptom onset had an adjusted risk ratio of 0.40. Overall, we see that even after adjusting for all risk factors, for example, whether you arrive early or late, whether you receive EVD-specific treatment or not, vaccination significantly decreased the risk of death for EVD-positive patients compared with not being vaccinated. So now let's look at our second objective, cycle threshold values at admission according to vaccination status. We assessed cycle threshold values for nucleoprotein at admission. We present here the median cycle threshold values and their interquartile ranges. Cycle threshold values were significantly higher, indicating lower Ebola viral load among those vaccinated 21 days or more before symptom onset, with a median value of 30 cycles, than among patients who were not vaccinated, who had a median value of 21.4 cycles. Cycle threshold values were also significantly higher, indicating lower viral load among those vaccinated 10 days or more before symptom onset than patients who were not vaccinated. And compared to the two previous groups, late vaccination had less of an effect on viral load, but still resulted in a lower viral load than not being vaccinated. In summary, cycle threshold values were statistically significantly higher, indicating lower Ebola viral load among all vaccinated patients compared to the unvaccinated. These findings on cycle threshold values at admission may explain, in part, the vaccine's ability to reduce the risk of death. Finally, let's look at our third objective, potential interactions between the vaccine and treatment. Monoclonal antibodies, the most effective EVD-specific treatment, greatly reduce the risk of EVD death in EVD-positive patients. As we have discussed in this presentation, the rVSV vaccine reduces the risk of EVD death in EVD-positive patients. There is the possibility of including monoclonal antibodies and the rVSV vaccine as components of post-exposure prophylaxis. Of note, the rVSV vaccine and monoclonal antibodies both share the same viral target, the envelope glycoprotein on the Ebola virus. Given this, if the vaccine and monoclonal antibodies were to be given at the same time or close together, it is not yet known if there would be an antagonistic effect. We looked at indications for this in our study. Let's look at what we found. So while in our study, the vaccine and EVD-specific treatments were not administered simultaneously, we were able to explore potential interactions when the vaccine is administered 4 days or fewer before starting treatment, as well as when no vaccine is given before starting treatment. Adjusted risk ratios were calculated taking into account age, time between symptom onset and admission, and EVD-specific treatment. A risk ratio above 1 is considered antagonistic, meaning there would be evidence of a negative interaction between the vaccine and monoclonal antibodies. while the risk ratio below 1 is considered non-antagonistic, meaning no negative interaction between the vaccine and monoclonal antibodies is observed. So compared with those who were treated but not vaccinated, those who were vaccinated and treated with Regeneron or MAB114 had an adjusted risk ratio of 0.29. Those who were vaccinated and treated with ZMapp or remdesivir had an adjusted risk ratio of 0.73. And those who were vaccinated and treated with an EVD-specific treatment had an adjusted risk ratio of 0.68. Although the results are not statistically significant, probably due to the small sample size, since all of these point estimates fall below 1, we can conclude that we do not observe an antagonistic effect. In conclusion, vaccination with rVSV greatly reduced the risk of death, even when adjusted for EVD-specific treatment, age group, sex, healthcare worker status, and time from symptom onset to admission. An additional observation explains the possible effect of rVSV on the reduction of the case fatality risk. Patients with EVD who were vaccinated showed higher cyclothreshold values at admission, signifying lower viral load compared with patients who were not vaccinated. This difference increased as the time between vaccination and symptom onset increased. Furthermore, our results suggest no antagonistic effect between the vaccine and monoclonal antibody treatment, even when administered within a short interval. It is important to vaccinate as early as possible to reduce the risk of infection, as shown by my colleague Sophie. But even late vaccination reduces the risk of severe complications of EVD, including death. Vaccination is better late than never. Our results highlight the possibility of using the vaccine as post-exposure prophylaxis. Importantly, as some EVD-positive patients who were vaccinated still died, the vaccine should be considered as post-exposure prophylaxis in combination with EVD-specific treatments. And I would like to acknowledge all partners, collaborators, and patients for their contribution to this research. Thank you very much.